everyone, and welcome to our presentation. We hope you enjoy the next few minutes as we take you through the evolution of replacing a limb. Let's face it, whether it be an IED blast, a construction accident, or some careless mistake, sometimes people get hurt. And when they get hurt, they don't always come back the same way. Maybe this clip will help to illustrate our point.
Now stand aside, worthy adversary. 'Tis but a scratch. A scratch? Your arm's off. There it isn't. But what's that then? I've heard worse. You liar. Come on, you pansy.
Okay. But in all seriousness, when people have limbs cut from their body in a traumatic event, the results can be devastating. An individual's life changes instantly, and things that once seemed simple to do become frustrating or nearly impossible to accomplish. Here's the chart. Thank you. Hopefully the next clip is going to help illustrate what Tim just said.
Amputations can happen to anyone, anytime, and anywhere, and your life immediately changes. So what do you do if something happens?
The first solution that comes to mind is the use of prosthetics. Mentions of prosthesis use have been around since ancient times. As a matter of fact, in the year 2000, the oldest evidence of the use of prosthetics was found in ancient Egypt. Prosthetics of this type were often used to hide deformities. It wasn't until the 1840s, with the advent of more sterile techniques and anesthesia, that surgeons were able to perform longer surgeries, allowing for the preparation of the limb for a prosthesis device. Even though the evolution of the prosthesis has helped many people, it had a few glaring problems. The patient's prior level of function could never be the same. The prosthesis was an obvious change to their body, causing some patients to view it as a physical deformity to be ashamed of. Lastly, the prosthesis wasn't really them. Patients often became depressed at the loss of the body part. Now, with the advent of new technology and medicine, we fast forward to today. When previously we asked, how can we help this patient cope with their new prosthesis? How can we help this person adjust to their new way of life? Now we ask, why couldn't we just reattach their limb? And I just happen to have a spare limb here laying around. Okay, this is where the process of replantation comes in.
Replantation refers to the surgical reattachment of a finger, hand, or arm that's been completely cut off from the person's body. The goal of replantation surgery is to give the patient back as much use of the injured area as possible. Now, it's not a silver bullet. In some cases, replantation is not possible because the part is too damaged or totally missing, in which case an amputation or prosthetic use probably would be the best choice. Now, replantation is typically recommended when the replanted part will work at least as well as the prosthesis or a complete amputation. Before surgery, the doctor will explain the procedure and assess the patient for the desire to commit to the time and rehab for the situation. Oftentimes, the rehab can take months, even years, to be effective. We'll have the pleasure of talking to Michelle Obispo, Doctor of Physical Therapy, a little later to actually explain what we can expect when the patient is rehabbing.
So how is the procedure done? There are a number of steps in the process. To keep things simple, first the damaged tissue from the remaining limb and the limb itself are clean, fully removed. Then the bone ends are shortened and reattached with pins or plates. These hold the parts in place to allow the rest of the tissue to be restored to a normal position. Muscles, tendons, arteries, nerves, and veins are then repaired. After that, you're done, at least with the surgery. Bend over.
So what type of recovery can we expect? Younger people typically have a better chance of getting as close to their prior level of function as possible. If you're a smoker, you should probably quit. Things in cigarettes, like nicotine especially, can impede blood flow to extremity, which might cause it to fall off. definitely not a good thing for reattachment. Right, so there's a couple of instances where a limb reattachment will be easier to make happen. So let's pretend this nutty bar right here, whole and delicious, is your arm or foot, leg, whatever it might be. It'll be easier to put it back together and reattach it if, number one, if it was cut, much like that, as opposed to if it was pulled or broken in half, or in the worst case scenario, which is really tough, if it was crushed. Recovery of use depends on two types of nerves. Sensory nerves that let you feel, and motor nerves that tell your muscles to move. Nerves grow about 1 inch per month. So the number of inches from the injury of the tip of a finger or toe can approximate the number of months before a patient may regain sensation or full movement of the extremity. Now, the replanted part never regains full use, but doctors typically consider a 60 to 80% regain of function a success.
What about therapy and rehab? For that, we go to Michelle, Doctor of Physical Therapy, currently working at UCSD Rehabilitation, for some quick information on the rehab process.
Okay, everyone, we're really happy to be here today because I have the pleasure of introducing my god sister, who's a doctor of physical therapy. This is Michelle Obispo. Hello, Michelle.
Hello.
Thank you for helping us with our presentation here. We're talking about limb reattachment today. Do you see a lot of limb reattachments and prosthesis, for that matter, in the hospital?
Yes,
or in the
I
rehab
do.
setting?
Mm-hmm.
Okay.
Yes, we definitely do see prosthetics use in the rehab setting. Typically, after an amputation, there's two options that you can have. You can either have a limb reattachment or you can have a prosthetic. In my department, we do more amputation and prosthetic management.
So, Shel, can you tell me a little bit about what the rehab for a patient with an amputation is like?
Well, you start off the process of rehab immediately after amputation. The reason being is that the affected side needs to be trained for transfers and balance training to serve as the dominant extremity. You can expect rehab to be about 6 to 12 months.
So, Michelle, what are some factors that you're concerned about as a physical therapist when it comes to rehabbing someone who's getting prepared for a prosthetic?
The factors I would be most concerned about are phantom pain, contractures, pressure ulcers, and deep vein thrombosis.
So, Michelle, can you describe what phantom pain is like for these patients, how they describe it to you when the symptoms manifest themselves?
Phantom pain generally occurs immediately after the amputation or 2 to 3 days after. Pain is not generally consistent, but it comes and goes. Symptoms may be described as shooting pain, stabbing, boring, squeezing, throbbing, or burning pain. It's typically triggered with changes in the weather or if there is pressure that's put on the remaining part of the limb, and it can be also evoked by emotional stress.
So, Michelle, can you describe what contractures are and what happens when you see a patient with them? Are they still able to do therapy, and if it's reversible or not?
Joint contractures are the chronic loss of joint motion due to structural changes in non-bony tissue, which include tendon, ligament, and muscle. Typically, contractures occur with muscle imbalance, pain, prolonged bed rest, immobilization, and typically we don't want to get to that point. We want to make sure that they don't get a contracture because they are not reversible.
Right, of course that means that it's non-reversible through just rehab. You could probably, you may be able to reverse it through surgery, but with just rehab, it's not reversible, and we definitely don't want to get to that point. We're talking about prosthetics and amputations, but what about limb reattachments? Fingers, toes, arms, legs. Have you seen that kind of stuff before?
Typically, I usually see digits and toes as opposed to whole arms or legs in my clinic.
So what can the patient expect after the limb is reattached?
Many people don't realize that the extremity will need to be splinted or braced for weeks to months. Without proper splinting, you can actually cause tendon, nerve, and vascular damage.
So, Michelle, what are some roadblocks to rehabilitation for the patient that you'd be seeing?
Roadblocks to healing include infection, wound healing, swelling, and pain management.
All right, so Michelle, we talked about the roadblocks to healing. We talked about infection, wound healing, things like that. These are all things that nurses are actually concerned about with their own patients, not just in the rehab setting, but in any setting as far as nursing goes. Can you talk to me about, let me ask you this. Have you ever had a bad nurse?
Yes.
Yes. What was that like for you as far as the actual rehab of the patient?
It was very frustrating. Patients were not able to get up because they were in so much pain.
Okay.
Or they were over-medicated.
Over-medicated, okay.
So that definitely was a really big component to getting the patient up and be safe while working with PT.
So would you say that the nurse's observations and assessments, before they even spend that 30 minutes, hour, maybe 3 hours for the day, is pretty important as far as the rehab goes?
Absolutely.
Okay. So let's look at the other side of things. Let's say you do have a great nurse who's actually watching the pain level, watching the assessments with their patients, very observant, and coordinating with physical therapy, occupational therapy. What can we expect as far as the results for the patient? Do you find it easier to work with them, and are they just having a better time with their healing process?
It's wonderful if you have a great nurse that's actually doing all the things that you're saying. Definitely for physical therapists, we have 8 to 10 patients that we see a day. So when we try to clinically coordinate when we're going to see the patient, they need to be actually physically ready, emotionally ready, and all their lines should be cleaned up and set up for us to get going. If we don't have a communication with the nurses, and let's say that the patient is having a bad day, emotionally on the forefront, it's really hard for us to get them moving. And if they are not being medically managed, especially with pain, because pain is a very big component to progressing in therapy, then we'll definitely have a harder time progressing them throughout their stay with us.
And now Michelle's going to take us through a quick exercise on how to prevent contractures.
Let's say that you had a below elbow amputation where they did a transradial amputation. So the two joints that I want to focus on specifically are the elbow and the shoulder to avoid contracture. So the first thing I'm going to have EJ do is actually do elbow flexion and extension. And so I'll do it passively, and then if he's actually ready to do active range of motion, I'll have him actually initiate the motion. So use your bicep to help me. Good. And come back. Another thing is, for the actual radius, it's responsible for doing radial deviation, supination and pronation. So go ahead and come here and there. Okay. And again, it goes from passive to active. Then I would move up to the shoulder, and I would have them do shoulder flexion, so come up with the head, locking the scapula, and coming back down. Here in abduction. Okay, if it's tolerable to 90 degrees, we have them here bend in this position and go into external rotation and internal rotation. And then you can do basic extensions that coming.
I have a question, Sean. I noticed you're using 2 points, like whenever you're moving the limb. Is there things you're feeling for when you're actually moving the patient? Can you tell if they're getting better or worse just by how they feel with the limb?
Yes, so I'm actually looking at quality of the joint motion. So for the shoulder specifically, there's the scapula that's influencing the amount of shoulder motion that I get. So if you have a tight latissimus or a serratus, then your scapula will come up too early with the motion, and so it might block and cause some impingement through here. So I'm looking at scapular kinematic motion, and I'm palpating the end feel for your glenohumeral motion.
Now, would you say that, I know we were talking about amputation, but as far as a limb reattachment, let's say it was a whole arm, would a lot of these exercises be pretty much the same for the patient?
They would be, but they would be coming later on in the protocol. So a lot of the times if you're actually doing a reattachment, or the surgeon is doing a reattachment, they want to splint. They want to splint the area for as long as they can for proper healing time. And then we start off with very, very light passive range of motion. We also start using different types of electric stimulation to try to increase the muscle recruitment.
Okay, thank you very much, Shel.
Mm-hmm.
And that is our time with Dr. Michelle Obispo. Shel, thank you so much for helping us with our presentation. We hope that what she taught us is able to pique your curiosity and really help you appreciate the physical therapist and occupational therapist role, for that matter, in the rehab of a patient with a limb reattachment.
Good luck on your nursing careers.
The Men of Cohort 32 would like to thank you for viewing this presentation. Our hope is that this information has piqued your interest. References can be found in the Information tab for this video if you wish to pursue more knowledge.